You find the patient's right iliac crest, which is the right hip bone, and the umbilicus, and midway between those two, right here, right lower quad, that's McBurney's point. Pain or tenderness here, bad sign, appendicitis. And here's another important thing to remember. Once you have palpated and the patient has complained of pain there, do not palpate again. Why? Palpating it again can actually cause the appendix to rupture. So at that point, you would tell the physician or the nurse practitioner, listen, positive pain at McBurney's point, and they would order either a CT scan or ultrasound, and the patient's probably going to go into the operating room and get that appendix removed. Okay, so make sure you know McBurney's point. All right, so let's go back to the PowerPoint. Okay, let me pull this back up again. Okay, as far as diagnostic tests, CBC, oftentimes with appendicitis, the white blood cell count will be elevated. And then, like I said, they're not going to do an MRI, but they're probably going to do an ultrasound or a CT scan quickly to confirm the diagnosis. And there is a nice little picture of McBurney's point, right? Anterior iliac crest. There's the umbilicus, and it's right around there. Okie dokie. Make sure you guys know that. That's an ATI contradictor question and a board question. If they do have appendicitis and they're going for surgery, nothing by mouth, right? Going to be NPO, and they're going to get the appendix out. I'm not going to talk about peritonitis right now because I get into that when we go into genitourinary. So peritonitis, I'm going to actually just kind of say here, there we go. I'm going to say NA for now, okay? Don't worry about that. Diverticulosis and diverticulitis. We'll talk about this real quick. So diverticulosis. A diverticulum is a little outpouching in the mucous membrane of the bowel. If they have diverticulosis, that means they have a bunch of those little outpouchings. If they have diverticulitis, that means that those little outpouchings have now become infected, inflamed, right? Here's a little picture for you, kind of make it real. So in the bowel, see those little pouches kind of that are sticking out? When a patient has this, they're actually pretty common, believe it or not. They have to be very careful about the foods that they eat. For example, fruits with seeds in them, or seeds in general, like sesame seeds or pumpkin seeds, rye bread that has the little seeds on it. Anything that's got seeds like that, the seeds can get hung up in the little pouches, stuck there. And then they can become inflamed and infected. And that's also very painful when that happens, when the diverticulum gets infected. Constipation that's chronic can be one of the causes. It's actually one of the most common causes. People that have colonoscopies over the age of 55, they used to recommend a colonoscopy every year for people over the age of 55. They have since lightened up on that, and they recommend a colonoscopy frequently, like every year, if you have a history of colon cancer or a family history of cancer. But if not, then every 5 years is the recommendation for colonoscopy. My point is that I've never seen a patient over the age of 55 that's had a colonoscopy where they didn't find either a polyp or a diverticula. So they're very common. The risk factors are listed here. Lots of animal fat and not a lot of fiber, right? Animal fat's not good for you, right? Obesity, sedentary lifestyle, smoking, and of course, certain medications are risk factors. There usually aren't any signs or symptoms of diverticulosis until they get infected or inflamed. Diverticulitis, they will have some abdominal tenderness, abdominal pain, which is usually what prompts the person to go to the hospital. So we control their pain, antibiotics for infection, have them on a liquid diet. And sometimes they can get so bad that the patient will need a surgical intervention. That's actually not common. but it can happen. And that is it for that. Crohn's disease. All right. So Crohn's disease is autoimmune. Okay. And remember, it falls under the umbrella of irritable bowel. Irritable bowel is just kind of like when we say dementia. Dementia is an umbrella term, but what kind of dementia? Is it Alzheimer's, vascular, Lewy bodies, frontotemporal? What kind of dementia is it? Irritable bowel. Is it ulcerative colitis or is it Crohn's disease? So we'll talk about Crohn's disease first. It is an autoimmune disorder, we believe. So the patient's own immune system is attacking their bowel. The bad part of Crohn's is that it is very erratic. It's very unpredictable. So it can attack different parts of the bowel at different times, sometimes for no apparent reason. And when it attacks, it actually is the white blood cells, your immune system attacking the mucosal lining of the bowel, usually the small intestine. And remember, I told you the small intestine is where all the absorption of nutrients takes place. So when the Crohn's disease exacerbates and it attacks a portion of the small intestine, it will erode it to the point where it becomes ischemic, lack of blood flow, necrotic, dead, and then we have to go in and remove it. I've had patients with Crohn's disease where they've had so many surgical procedures where a portion of the bowel is removed, another portion of the bowel is removed, another one is removed. Excuse me. They wind up with something called short bowel syndrome. In other words, there used to be 20 feet of small intestine. Now we have 2 feet left. And that's bad for lots of obvious reasons. They're going to have nutritional deficits, right? Because the food is only passing through 2 feet of bowel. It's not enough time for the body to take out the nutrients that it needs. It can be so bad. I had one patient in Atlantic City. God, this was back in like 2003. She lived with her 12-year-old daughter. Back then, we didn't understand it as much as we do now. We still don't fully understand it, but we have a better handle on it and a better handle on treatment for it. But she had had her 5th surgery. She had 1 foot of bowel left. She had an ileostomy. She had scar tissue. She had fistulas everywhere. And she had her 12-year-old daughter, which was her only caregiver, that I was supposed to go teach how to do her TPN and lipid infusions into her port and manage her wound care. I mean, it was horrible. I was at this lady's house twice a day, even though I wasn't supposed to be. But I felt so bad for her. She was young. She was in her 30s. We don't know what causes Crohn's. We don't know why some people get it and others don't. We do believe there's a heredity factor in there, but it's not absolutely definitively conclusive. So Crohn's disease can kill you. Ulcerative colitis won't. Okay? So Crohn's is the worst. It usually starts off with abdominal pain, cramping. They'll start losing weight simply because they're not absorbing the parts of the bowel that are becoming ischemic, and then they'll have diarrhea, and then it progresses from there. What do we do to diagnose it? Usually we'll do endoscopy, which is scope down the esophagus to biopsy either the stomach or part of the esophagus, or colonoscopy, going through that way. It's easier to get to the small bowel through the esophagus than it is through the colon, if that makes sense. Okay, we can do ultrasounds and CT scans as well. Even though there are lots of things listed here for therapeutic interventions, I'm going to tell you that corticosteroids and immunomodulators are the biggest. Biologics are there too, so we'll talk about all of those in a second. Let's start with the biologics. Etanercept, I'm going to put that on here. Etanercept is a biologic, and adalimumab, that's a mouthful. Those are biologics. That's also called Humira. You might see that advertised on TV. Those are biologics, and what they do is they actually suppress the immune response. And because we know that the immune system is what's attacking the bowel, we kind of have to shut it down. And so these biologic response modifiers will basically shut down the immune response. And so you can only imagine that the side effects would be like risk for infection, right? Makes sense. Corticosteroids decrease inflammation, right? But what else do they do with long-term use? Suppress the bone marrow. If we suppress the bone marrow, we suppress the production of red blood cells, platelets, and white blood cells. If we suppress the production of white blood cells, well, then they're not there to attack the bowel anymore. And corticosteroids, prednisone, prednisolone, methylprednisolone are examples of those. Oops, no typos. And then immunomodulators. And there is a drug that you definitely need to know. And it's one of the drugs that I believe is on this week's for med templates, methotrexate. Methotrexate is an old drug. It has been around for years and years. It is a chemo drug used for breast cancer a lot. Chemotherapeutic drugs, pretty much all of them, methotrexate included, will suppress the bone marrow. And again, with Crohn's disease and all autoimmune disorders, actually, for that matter, what we're looking to do is shut down that patient's immune response so that their immune system can't kill them, right? Methotrexate, and ATI and the board love to ask about methotrexate. So please make sure you know methotrexate like inside and out. Therapeutic interventions. So if the patient needs surgery to have part of that bowel removed, remember, the small bowel, absorption of nutrients, more often than not, the patient's going to have a central line, okay, which a port, mediport, porticap, implanted port, a port that's implanted in the anterior chest wall that is directly connected to the superior vena cava for infusion of TPN. TPN is total parenteral nutrition. And what that means is we can't give the patient anything nutritionally that's going to go through their digestive system at all, right? Think about it. If I'm taking out part of your small bowel, I need to give your entire GI tract a complete rest. So when I do that, well, you need nutrients. TPN is an infusion. It's IV, intravenous, of all the nutrients that a patient needs. It's got a complex algorithm that determines the formulation of the TPN with the mixture of lipids and proteins and carbs and the essential elements and vitamins and minerals and all those things. That's based on the patient's BMI, et cetera, et cetera. Remember this with TPN. As an LPN, if you are assigned a patient that's on total parenteral nutrition, two things. Number one, notify the charge nurse or the RN. And number two, the biggest risk of a patient on TPN is the risk for hyperglycemia, okay? Hyperglycemia. When we administer TPN, it's typically given and it's ramped up to simulate the way we would actually eat normally. And the patient is going to be having their blood sugars checked at least 4 times a day as if they were diabetic. And they're going to have a sliding scale of insulin, regular insulin, available as well when they're on TPN, simply because that risk of hyperglycemia is extremely high. Make sure you know that, okay? Okay. Complications, obviously malnutrition, that it's the small bowel obstruction from the dead or dying tissue that's in the small bowel. Fissures, cracks in the lining of the bowel tissue. Abscess. An abscess is an infection that encapsulates and starts to collect purulent exudate, pus. So that's dangerous. A fistula. Fistula is an opening that is not naturally in the body, that occurs because of an erosion or a tunneling. Let me try to show you what I mean. This is a picture of fistulas, different areas. I don't know if in this you can see it well, but you'll have the PowerPoint to look at, and I'm going to make this bigger. So this is a side view, transverse view of a female patient. And here you can see, you know, from the front, like this is the urinary bladder right here, okay? Here's the woman's uterus right here. Here is the descending colon and the rectum leading to Uranus. This is the vagina. This is the urethra, okay? With Crohn's disease, when fistulas start to occur, as the erosion